So we're gonna start now. So my dear audience, I'm so glad to reach this International Congress of Cardiology through this webinar, even if I'm a little bit sad because I cannot meet you all because of the sanitary restrictions. And I would like to thank a lot Gabriela and her team for this incredible work and organization. So today I'm going to do a quick presentation about this unclear syndrome, which is the takotsubo syndrome in the postpartum, used in a case we had this year in our obstetrical unit. So first of all, we're going to start with an introduction. We will give a small definition of the takotsubo syndrome. So the takotsubo syndrome it was introduced by Sato and Dodds in 1991 and 1990 to describe the left ventricular silhouette during the systole. Its physiology remains unclear, and the management is relatively unknown. And epidemiologically, this pathology occurs preferentially in women in the immediate aftermath of an intense mental or physical stress. So to discuss more this cardiac condition, we report the case of a 46-year-old patient who had 6 infants living vaginally. She had no cardiovascular risk factors and no particular pathological history other than a myomectomy in 2020. And she was pregnant at the 35 weeks of amenorrhea. And she was admitted to our maternity unit in a non-reassuring fetal state associated with severe anemia. When we talk about her physical examination, our patient were conscious. She had a cardiac frequency about 120 beats per minute. She had normal blood pressure, and she had polypnea at 25 cycles per minute. At the gynecological obstetric examination, the uterus was relaxed. She had no bleeding, and the cervix was dilated at 1 centimeter. But the fetal cardiac activity was present, but he had severe fetal bradycardia at 42 beats per minute. So we rushed our patient to the operating room for a fetal extraction by C-section under a spinal anesthesia. So in the operating room, after the spinal anesthesia, the C-section gave birth of a newborn male who had an Apgar score 0 out of 10 and with no cardiac activity, even after the resuscitation procedures. On the exploration, we found a posterior phandic rupture of 4 centimeters associated with the pneumoperitoneum. As we can see in this picture, it was a posterior phandic rupture, and this posterior phandic rupture were responsible of hemodynamic instability, and we had to introduce our patient the noradrenaline, and we did the transfusion of 2 red blood cells. Then the patient was transferred to the obstetrical intensive care unit. But at the second day, at the intensive care unit, our patient presented a sudden onset chest pain radiating to the neck and left upper limb with arrhythmias. These arrhythmias was particularly marked by bigeminal extrasystole, as you can see in this picture, and an attack of ventricular tachycardia. Then we made an electrocardiogram objectifying a nasty segment elevation in the anteroseptoapical and inferior segments. We did even a blood analysis objectifying an elevation of the troponins about 40,585, and we did a transthoracic heart echo too, where we objected an hypokinesia about the left ventricular in the anteroseptal and inferoseptal walls. After all, the patient underwent a coronary angiography for the suspicion of the NSTEMI, which returned normal. As we can say, the common trunk is of normal length without stenosis. The anterior interventricular artery is medium in size and free from significant lesions in all the 3 segments. And the circumflex artery is of all normal size dominant without stenosis. And the right coronary artery is dominated small in size and free from any significant damage. 2 weeks later, the electrocardiogram returned normal, and the echocardiogram showed a complete recovery of the left ventricular systolic and diastolic functions. So, the takotsubo syndrome is an acquired cardiomyopathy with transient and reversible left ventricle dysfunction that can mimic acute coronary syndrome, and that was the case of our patient. But we should know that the takotsubo syndrome in the postpartum is a different clinical entity from the peripartum cardiomyopathy, or what we call the Meadows cardiomyopathy. When we talk about the diagnosis of the takotsubo syndrome, is based on the Mayo Clinic diagnostic criteria. It includes the presence of transition akinesia, hypokinesia, or dyskinesia of the left ventricular with or without apical involvement. This regional defects in ventricular wall movement extends beyond a single epicardial vascular perfusion territory. Additionally, there is no obstructive coronary artery disease or angiographic evidence of acute rupture of a plaque. The patient might also have ECG abnormalities such as an ST segment elevation with or without a T-wave inversion or moderately elevated cardiac troponin levels. Our patient had transient electrocardiogram abnormalities and no angiographic coronary evidence of acute plaque rupture or vessel occlusion, meeting the Mayo criteria for the takotsubo cardiomyopathy syndrome. When we talk about the etiology and the pathophysiology, it remains uncertain, but it seems that the sympathetic system appears to play a central role because when we have an emotional or a physical stress, it will be responsible of a sympathetic system activation, which will give a catecholamine abnormal release, then a cyclic calcium overload mediated by the NPM, which will be responsible of a microvascular dysfunction and the cardiotoxicity given our takotsubo syndrome. So when we talk about the emotional stress and the depression, the presence of the depression in this type of pathology, as we know the takotsubo syndrome, has been reported in several studies. As we can say, at the study that have been done by VD, 21% of patients present with a depressive or anxiety disorder, this factor being more present than other cardiovascular risk factors, such as smoking or diabetes. And there is a study that has been done by Mood. They found a prevalence of depression and anxiety disorder of 40% in 110 patients with levels of catecholamine, especially norepinephrine in depressed patients. But regarding our patient, she presented several factors explaining the occurrence of the takotsubo syndrome. First of all, she had presented in a hemorrhagic shock following the uterine rupture, causing an hemodynamic instability and the massive involvement of the adrenergic system. The second factor is the vulnerability of the patient in the absence of an emotional expression, especially the difficulty of adapting the neonatal death that she just had learned about her little child. When we talk about the treatment, therapeutically, treatment during the acute phase of characterized feature of the takotsubo syndrome is spontaneous resolution in hours or weeks. Therefore, treatment in the acute stage should be supportive and focus on appropriate treatment of complications, but there are no controlled studies or guidelines on how to treat the takotsubo syndrome. So as a conclusion, the prevalence of stress cardiomyopathy is rare, and the pathophysiology of this disease remains to be defined. The case that we have presented highlights hypovolemia as a complication of any childbirth, as well as the emotional state of a patient in the peripartum may predispose to this type of pathology. This implies that the risk of any event may depend not only on the person's cardiovascular vulnerability following exposure to stress, but also on their mechanism of coping. Thank you.